Hey, very good morning, everyone. Um, we are here live on yet another session for a very important topic. Uh, we are meeting on 14th of June 2025, and uh, these are all medical association meeting from Simao. To talk about, we have Dr. Colonel Kumud Rai to talk about the ECHO model of skilling and strengthening healthcare professionals in India. Dr. Kumud is a
Mr. Sora, Mr. Sora, before this, I will request all of you to extend the heartiest condolence to our brother and sisters who were killed in the air crash in India.
Thank you, Professor Musalim, and very grateful. And let's all begin with a few seconds silence in remembrance of this very tragic incidents, which took away more than 270 lives, both those on the plane and some of them on the ground. Thank you for pointing this out.
Thank you, Dr. Bukhari. Let's keep it silent for 2 minutes. Thank you. I would also like to thank all the medical associations who have written and shown their concerns and support. So thank you so much. And we would like to move forward with the session now. So thank you, Dr. Kumud Rai, for having this session for us. The session topic is the eco model of skilling and strengthening India's healthcare workforce. He's a chairperson and managing director for ECO India. He's a director of vascular surgeon for Max Super Specialty Hospital in Saket. He's a renowned vascular and endovascular surgeon. Dr. Rai brings him decade of experience in both military and civil healthcare leadership. Sir, over to you.
Thank you, Saurabh, for the kind words. And before I begin, I would like to pay my homage to late Dr. K.K. Agarwal, an outstanding human being whom I had the privilege to meet once I left the armed forces and joined private practice in Delhi. And he was a very large-hearted man, very active amongst the doctor community. And without knowing me, he invited me to one of the DMA meetings and requested me to present the work on vascular surgery almost a decade ago. And when I was in a tight spot answering a question, because I was a surgeon in the armed forces, didn't know much about the financial aspect of it, he jumped to my defense and he said, "Look, such and such operation, even a piles operation costs X amount of rupees. So what's wrong if varicose veins are costing this much?" Uh, Dr. KK was familiar with the ECHO model. In fact, for one of our meetings, we invited him. I think this was the year 2018. And he did come and he participated. He gave his insightful comments. And later on, he even sent me a short poem on the ECHO model. He had a wonderful way with words. So a lot of gratitude, a lot of remembrance to Dr. KK Agarwal.
Thank
So
you, Dr. Rai.
what does ECHO stand for? The full form of ECHO is Extension for Community Health Outcomes. That means the model is designed to improve the health outcomes of a community. So there is a model and there is an organization, and I'll talk mostly about the model because I think for practicing doctors, those of us who are inclined for doing public good, and I suspect vast majority of us are, this gives us a chance to amplify the good work we are doing and bring value in the community. This is a bit about myself. Dr. Saurabh has already said uh, a few of my achievements. I was the past president of Vascular Society of India and of the Vascular Society of USA India chapter, a counselor for European Society for Vascular Surgery, was awarded Sena Medal for my services during Kargil War. I was posted there in Srinagar, and we treated at that point over 1,000 casualties, and our mortality rate was 1.2%, which was lowest in the world. Now, coming to what is this echo model? What is different in this model? So it is essentially a mentoring model which while uses technology. I wouldn't call it telementoring. It is more than that. We amplify the technology to leverage scarce resources. It is difficult for people to come in this day and age for physical meetings. So we use platforms like Zoom to connect with them at a given date and time, and to mentor them, not really to teach them, but to mentor them in a particular disease or a particular part of the disease. For example, there could be an echo for diabetic retinopathy or an echo for blindness. The second thing, so we like to call it the ABCD, sharing of best practices. And these best practices are global best practices, but also the national best practices as applicable. The experts, while they're sharing their vast knowledge and wisdom, they try and remain within the best practices which are applicable in the community and in the country. The unique thing about this is a case-based learning to master the complexity of treating a condition, and I shall tell you how that happened in hepatitis C. And finally, we have we monitor the data, not the patient data. That is absolutely confidential, but outcomes of the mentoring that is happening. So that's the ECHO model in short. Essentially, what happens is a cohort of people, and typically this is somewhere between 20 to 40 people. They are the mentees, and they meet a mentor or a group of mentors who talk about a particular aspect of a disease for a few weeks, for a few months, or maybe a few years also, till that person becomes confident or even an expert in managing the disease. The model is applicable not only to doctors. We all in medical school have learned this way. We have presented cases to our bosses and learned from their wisdom, improved ourselves, but also for other healthcare workers, right from the grassroots, Asha workers and Anganwadi workers to nurses, ANMs, CHOs, the entire lot. So this is what is the sort of difference between the classical teaching and the ECHO model. Classical teaching, as we all know, is of course led by the specialists in that field. It can be by conferences, it can be by courses, it can be by workshops, it could be by webinars and things like that. In contrast to this is a very stylized sort of uh, thing which is done. It's on a virtual platform. It tries to create a community of practice led by specialists. Case presentations are led by participants, and in a typical 1 hour session, there could be 2 or 3 cases, real life problems which are presented by the participants and discussed by the specialists and the other participants how best to manage them. It provides mentoring and support, and it creates a feedback loop for continuous refinement and improvement. And I've talked about evaluation also. For example, if there is an echo on management of diabetes, a participant, a young doctor, maybe just plain MBBS, in a rural area can present that patient, tell the challenges, what are there, is there any neuropathy, what is the HbA1c, the treatment of the medicine, what would be the best medicine applicable for that person, and during the course of the treatment, did the HbA1c come down? Were there any complications? Were there any side effects of the drug? And by attending these weekly or bi-monthly meetings over a period of time and solving real life cases, these people become experts. The credit goes to a gentleman by name of Dr. Sanjeev Arora, who incidentally was born very close to Delhi in Faridabad. He migrated to US in 1980 and he's lived there since. He's the Distinguished Professor of Medicine at the University of New Mexico at USA, Ashoka Fellow, Levinson Fellow, Heinz Award, numerous awards, and a lifetime Governor's Public Service Award for care. He's an amazing person, and during his introspections, his meditations, he was able to find out or sort of formulate this model or discover, if you want to call it, and he put it in practice. So this is how it looked like. That's Dr. Arora with his colleagues. There is infectious disease person, there's a pharmacist, and there is support staff. And here are the 8 or 9 people who have joined it, and they are presenting cases. And this began with hepatitis C, because with Dr. Arora, a young woman in her late 30s once walked in with her 2 children, and she told her that she has got hepatitis C. So Dr. Arora asked her how long, and she said that, well, I have had it for 12 years. He said, why didn't you come to me earlier? She said, I'm a mother of 2, I'm single, I can't drive 100 miles, and I was told that I'll have to come 12 times because hepatitis C was then treated with interferon and ribavirin. And so he asked him, why have you come now? She said, I have a pain in my upper abdomen. So a scan was done. She had a large cancer in her liver, which is not unknown in hepatitis C. She died a few months ago. So Dr. Arora said, why is it that in one of the best countries of the world with a good healthcare, with lots of billions of dollars spent on public spending for a notifiable disease, which is treatable, treatment is free, why are people dying? So he got together hold of, and New Mexico is a bit of an underdeveloped state in like those in India, and he got together 21 healthcare specialists and asked them that if I mentor you, will you please monitor or will you treat these cases? They said yes, and they started treating. Few years down the line, year 2011, he published a study. He did a trial in New Mexico wherein people were treated at the university hospital by him and his team and by these people. And there was an outcome. What was the status of viral markers at the end of the treatment? And he found that there was absolutely no difference between the outcomes, whether they were treated at the university hospital or by the specialists under the guidance of staff of New Mexico. This was published in New England Journal of Medicine, and the moment it was published, the world kind of took notice, and ECHO is now there in over 170 countries, learners in over 170 countries in the world. So this is a bit about the history of the ECHO model. And this is the specialist team, which I had just talked about. And there are the primary doctors, and they in turn go out and treat hundreds and thousands of patients within the community. So it has a true cascading effect, which can, and you know, all the people join in at the same time. They can see the same screen. They can offer their comments, and it's not a passive learning, but an active dialogue, which helps these people to learn better. So what is the evidence of data? And I'm only talking about the data from ECHO echo of echo in India, and this is listed here. These are the papers which are published. NIMHANS Bangalore is the leading institution which has published 17 papers. National Institute Echoes, they have presented 8 papers. ILBS, Echo India's, PGIMR, Chandigarh, NITRD Delhi, All India Institute of Medical Sciences, Ummeed, and many, many others. Globally, there are more than 650 publications attesting to the efficacy of the model, wherein it is shown that not only the participants benefit, but the community also benefit and the patients also benefit. So this is one of the examples of the NIMHANS Echo blended telementoring model for mental health and addiction for counselor in rural and underserved areas of Chhattisgarh. So it's a model now, or it's been in use for close to 2 decades, in India for 1 decade, and it is very, very kind of useful if you want to improve the knowledge, the skill sets, and the outcomes in communities. So Echo India is a not-for-profit, i.e. charitable trust, and we want to empower frontline workers with the right medical knowledge so that the community can benefit. We are very proud to say we are there in all the states of India and all the union territories, and our focus has also been Northeast, wherein because of the geographical barriers and many other problems, healthcare can be difficult to deliver. So we focus on capacity building and skilling of workforce in India, but no individual or no organization can do it. And we go in partnership with like-minded people, doctors, educationists who want to run their echo clinic, and we encourage them to do that so that the community in large can benefit in India. So this is our sort of roadmap. We came into existence in 2008, but really started working in 2014 when the internet 2G and 3G services became available. Before that, we used to use polychrome bridges, and that was our first echo started at Maulana Azad Medical College and the national and the AIDS NACO, but it couldn't take off because of technical issues. So NIMHANS, NIP, CPR, NITRD were one of the first early adopters and have remained with us for this decade and have done wonderful work. In 2018, the NTEP adopted the ECHO model, and now the ECHO model is used extensively for skilling of healthcare workers in tuberculosis, in their regular meetings, etc. The various NHMs, National Health Mission, started adopting the model, and we promised with NHSRC and launched the first program on hypertension with ECHO. We find an overarching agreement with the Ministry of Health and Family Welfare in 2019, wherein it said that ECHO will be the preferred model for skilling of healthcare workers. As of now, we have 500 hubs. Hubs are center of excellence. Anybody who wants to run an ECHO program with over 1,200 completed programs. We ramped up very rapidly during the COVID challenge, and very lately we have started foraying into agriculture and education. So this was the response in COVID-19. These were very, very difficult times. Everybody knows that. And during that period, in about a year and a half, 2 years, 3,000 sessions were held. Over 7 lakh attendances were there on those webinars and ECHO programs which were there. And ECHO provided over 5,300 hours of training during that time. So we also trained in Mumbai and Kolkata 5,500 nurses in Infection Prevention and Control Program, IPC program, which had its focus on COVID, but also other infectious diseases. Thereafter, we have conducted a long COVID program by mentoring over 1,000 medical officers and nurses through echo sessions and webinars. So this is the expanding universe of care. These are the national programs which adopt the ECHO model, the PMJ program, the viral hepatitis program, NTEP, National Cancer Screening Program, National Mental Health Program, etc. These are the people we focus on: doctors, community health officers, nurses, dentists, counselors, ASHA and A&M workers, school leaders and teachers, and even specialists in some instances. The good thing is that this model is disease agnostic, i.e., if you are an expert and if you feel that there is a gap in the community, amongst the community workers regarding this condition, you can use it. It can be used for cancer, COVID-19, hepatitis C, maternal and child health, non-communicable diseases, over 80 disease areas. As I said, that we are in all states and union territories, and the sum of attendances in the various ECHO programs has exceeded over 25 lakhs. Our intervention in TB, I'll talk about it once again. There are over 8,000 sessions conducted. There are 115 hubs, and we have, as you can see in this map, over 100% geographic coverage of India. The two key institutional partners are NITRD and NIRT, and TEP uses ECHO as the preferred model. And we have collaborated with international agencies as well who support the TB elimination program in India. 80% of the NTEP staff, 25,000 plus, have undergone training on this model and use this model. And the Central TB Division and state training centers, state task force, DGs, etc., are using this model regularly. I'd like to present a case study on the addiction management in Bihar in 2000. And in Bihar, there was rising alcoholism, and in 2016, when the prohibition came, there were a lot of cases of delirium tremens and psychiatric disorders, and the doctors in Bihar were unable to deal with that very effectively. So NIMHANS jumped in, and it trained 27 doctors under the Basics of Addiction program. Then they had a blended mental health training model. And the patient impact has been that in a single year, in 13 months, these doctors treated 23,000 patients facing addiction problems and mental health challenges. So this is how the effective model can be. You can pick up a disease which is of public health interest, which is a problem, and try and address the gap in the knowledge and education, especially in the remote, rural, and underserved areas. Similarly, there was a cancer screening program which was carried out in Chhattisgarh in 2022. There were very limited awareness and screening facilities, and we focused on oral cancer, breast cancer, and to some extent on cervical cancer. And these doctors applied, they were all in the public health domain, and these patients were able to receive treatment, because you ask, oh, what's the point if you detect, if nobody does it, people jump in. So Kedwai Institute in Bangalore, for example, jumped in and said, if you have any suspected case, please send to us, we will treat it absolutely free of cost. This is regarding the partnership with the Directorate of Health Services Punjab. This was again for hepatitis C, closer to home in India. At that point of time, only about 1,500 patients were being treated by the PGI Chandigarh doctors. There was a massive program. Of course, lots was done, lot of publicity, lot of medicine availability, lot of detection cases and mentoring of these doctors who were there in government institutions and who helped. And this list has grown now to more than 150,000 patients annually. So this is how effective the ECHO model can be in skilling of healthcare workers to tackle public health problem. We have recently, we are about to finish a nationwide program on the prevention and control of beta thalassemia and other hemoglobinopathies. This is a very, very specific problem in certain states in this country. And you can see the Honorable Minister, then the Minister of Tribal Affairs, gracing this program virtually. And the program has been the Kolkata Municipal Corporation, Brihan Mumbai Municipal Corporation, and GMC Bhopal. These were the three areas. There were medical officers, pediatricians, which were trained. And, this is at these were the hub leads. And the main this thing was at New Delhi, or rather in Noida, at the National Institute, and it has gone off very well. A recent example is a CATCH program for TB care in J&K, CATCH standing for Collaborative Action for TB Control through Community Health Officer, wherein we train the community health officers, over 400 of them, through a structured 12-module curriculum, retaining the heart of the ECHO model, i.e., and case-based learning. And we taught them about the TB prevention, diagnosis, treatment. And guess what? They were able to identify 8 TB positive cases within the next few months in J&K by applying this, by learning through this model and by applying it. And the voice from the ground was, the program has helped us achieve what we have been trying to do from last 1 year. And in the district of Kupwara especially, it was very difficult to connect with the patients, and I could only visit, the person is saying, only 75 families. Through this program, we were now when connected with all the workers and most of the families in the community. We are also there in the education sector a little bit. This model is also very ripe for use of those of us, and many doctors are educationists as well in their own field. So we have 36 hubs in education, total 81 programs, 909 sessions, and 31,000 school teachers. And we believe we do not target the students. There are enough organizations in the country which do that. But we believe that if the teachers are taught or they are skilled, they can help literally thousands of students within their lifetime of their teaching career. So our focus areas have been early childhood education, student engagement, foundational learning, school leadership, STEM education, school safety, adolescent health. And lately, we have started this program called ECHO Nai Disha, where we are helping the adolescents grow with confidence, and this national teacher training program, which helps educators support adolescents through their physical, emotional, and social transitions. Over 12 expert sessions for 6 months. That means through a month, teacher can learn how best to face these challenges, to apply them in real life, in their classrooms, and improve the outcomes. This has followed a gender equity program which we ran for ECHO. So how do we support all this? We have our own iECHO digital infrastructure, which is a digital platform. And It makes the job very easy for the person who's conducting the echo program. You can get automated attendances and reminders. You get an integrated feedback. You can plan, you can post your curriculum, you can issue certificates, and it breaks geographic barriers, and it leads to even more collaboration in this echo programs. It is easy. It is optimized for low bandwidth. It is optimized for mobile first, because in many of the rural areas, everybody does not have an access to a laptop or a desktop. We now have automatic translation in 20 odd languages, some African languages, but mostly Indian languages, and it is compliant with the accessibility standards. So those of us who choose to do it, Echo India would help them. We give everything free. We don't charge anything. Anybody who's interested in running a program, we ask them to sign a non-binding MOU that this will not be used for commercial purposes, and bingo, you are good to go. There is no cost involved in it. And it helps in the scalability, as I said, breaking geographical barriers. It can even be used for disaster preparedness and response. And this is a program which is being started for school children and school teachers for disaster preparedness and response. It is very cost effective, and it is one way of reducing the transactional cost, as I said. There have been some achievements for the model and the organization. And for our work, we were honored by the Mahatma Gandhi Award. That's Dr. Sunil Anand, our executive director, receiving it. At the SOCHM Summit in 2023, we received 2 awards for in that as the best innovative model. Also, at the Financial Express Awards last year, we were awarded the Best Public Health Initiative Award for promoting community health and well-being, and also the National Icon Award, which I received on behalf of Echo India. At the HCL Foundation's Partnering for Change, Echo was honored with the Best Practice Award in the health category for impactful primary healthcare training for community health workers in northeastern states, Nagaland, Manipur, and Mizoram. So this is the philosophy that guides us. It is, while I said that the experts teach, but in reality, what happens is the entire community of participants who are there also sometimes give very insightful leads or insightful management strategies. We believe in moving knowledge, not people. We don't want people to come to Delhi or any big place or any state capital for courses. This can be very labor intensive and financially also. So we try and move the knowledge to the patient and not the patient coming to learn. We are using technology for equity. This digital platform is trying to bring in some kind of equity in healthcare, especially in remote areas. We are trying to strengthen the systems at scale. And the philosophy is people always come first. That is why there are case presentations wherein real life challenges, real life patients are helped, and it's not academic. Everything is available these days. For example, there are MOOCs, there are libraries, there's AI, but how to apply the given knowledge in a given patient is what Echo teaches, and how it improves outcomes. And we are a kind of a platform where you can use, while we provide service, we believe that it's a platform which anybody can use, get up and run with. So if we want to reduce disparities in healthcare in underserved communities, we want fairly rapid dissemination of best practices. We want better preparedness for tackling emergent situations, and not last and in the end, but not the least, a sense of doing public good and giving back to the community. Many of us feel that doctors feel, oh, we are doing public good anyway. But if you want to go beyond and truly help the patients and the healthcare workers in remote and rural areas, this might just be the ideal model for all of us. With that, I come to an end. I have deliberately kept this presentation a little brief because I wanted to discuss this more as a concept than anything else. And Echo India would be very happy to collaborate with anyone who wants to run an Echo program. Thank you. Thank you very much. And thank you for the privilege of addressing such an august audience. Thank you.
Thank you, Dr. Kumud Roy, for the wonderful session and the insightful knowledge about the topic. I would like to now open the forum for question answers. Anybody who has questions, please come forward and ask.
Thank you, Dr. Rai. That is a fantastic presentation of incredible work on multiple different layers between those who are educated in the healthcare and with the ground workers who are able to extend the knowledge to the people who will benefit from the knowledge. I am familiar with some of ECHO's projects, living on this side where Dr. Arora started his projects here as well. But what do you identify as still being unmet needs? What are the biggest areas that still need to be addressed within India or globally that you see that ECHO can provide the knowledge, the resources, and the pathway for improved health globally?
Thank you for asking that question, Dr. Monica. And it can be a little challenging because in a country like India, where with all its myriad problems, where do we begin? What do we do? So we have employed the agnostic approach in the sense that we go to the community, try and find out what is the problem which is bothering them, and then try and give a solution. See, if we think, oh, this is a perfect model to disseminate about this particular disease, there may be no takers because that might not be a problem. So in Punjab, it has been hepatitis C. In perhaps pan-India, one of the biggest problems is two big problems are cancers and lifestyle diseases. And we have started an ECHO program where we are addressing the three main problems of diabetes, hypertension, and heart disease, also obesity. And we are trying to find a sense of whether it is actually helping the community or not by doing some simple tests like lipid profile pre and post, like HbA1c pre and post, and a few others. So we have left it to the community because, as you can make out, this is purely a voluntary thing. Whatever is the need of the community. And that is why we have pivoted slightly onto education. By the way, we are running this in agriculture as well. We are training now literally thousands of agriculture workers. And you'll be surprised at the traction we are getting there, not only from the workers, but also from the government of India on the best agriculture practices. Somebody is mentoring you. It's not somebody comes you one-off, gives you a lecture, and for 6 months or 12 months, you are left on your own to fend for yourself. You apply that knowledge, the worker applies that knowledge and comes back and say, well, buddy, you said this would work. It's not working. And we try and figure out what was the intervention which has not worked. So thank you for asking that question. I honestly don't have an answer, and we are willing there to help anyone and everyone in this. Thank you.
Mr. Sarab, can I ask the question?
Go ahead.
Thank you so much. First of all, thank you, Dr. Rai, for giving very informative lectures. No doubt the same problem in India and Pakistan we have here. Let me know, because most of our 60% population is in rural areas. and hopefully same will be in the India. What strategies you will apply? And it is not the work for one day. It takes time, longer time to educate, to prepare the team. Okay, what strategies you have applied to prepare these things like in our rural areas, like in PHU, RSC, and these areas. One question. Second question is that from the last, not only we are suffering hepatitis, same in Punjab and Pakistan, hepatitis C and other diseases. We are looking at from the last 2-3 years in Punjab and Pakistan. I do not know the condition of. We are suffering with the problem of agriculture because our cotton, the agriculture has not no more growing this one. How strategies you can recommend for the people of the rural areas to they should come and show that we can redevelop this ecosystem in Punjab and especially in other areas. Thank you.
Thank you, Dr. Bukhari, for asking that question. And it is a tough job. I think the first thing which works is, and that is very difficult, is to have the government buy-in. See, we cannot have a system parallel to that of the government and say, look, we are doing this and you are no good. No, we go to the government and we say that here is the problem. And this is the problem. And would you like something to be done about it? And what does the government do? Incidentally, we don't even take money from our own government. We do it pure philanthropy. We say that if you is there, do two things. Get us experts and get us the community of people who want to learn. Now, if these two things are there, then it becomes relatively easy for any intervention to be carried out. Like as you're saying, for the crop problem, the farmers who are there, who's facing this problem, there, I'm sure there are ground workers who help them, who teach them something. So you get those community workers on, you get an expert, you get government buy-in, and that ensures in a way that these people will actually attend, because there's a lot of good in the world. And many people believe if you give something free, nobody will value it. So keeping that in mind, when the government is with you and they are telling their people that, look, you do this and try to of our brothers and sisters, whether they are having a medical disease, whether they are having an agricultural problem, it helps. It takes a lot of effort. When we started, it took us almost 5 years. They would ask, where is the proof of the model in your country, in our country, in India? So the same thing they're likely to ask you. I think the Aga Khan Foundation in Pakistan is running. They do it directly through what is known as the Echo Institute. There is an Echo Institute in New Albuquerque, New Mexico, and they work directly with them and they give them guidance. But if I can be of any help, I'll be very happy to do so.
Thank you so much for nice.
Dr. Rai, do you have any mechanism where you are integrating this entire system in India with the framework of national health like Ayushman Bharat and all that?
Yeah, so when we were there, Dr. Saurabh, they wanted us to use the national platform, and those platforms had so much wanting. I mean, things would never work. So now with the proof we have said we have now trained more than 2.5 million workers in India, which is a huge number. And now we are talking to them that if this module can be adopted as a digital public good by the government of India, because we don't charge anything for it anyway. The talks are still on, but I think it will take a little while to convince the government to use it. But that's our ultimate goal. Build, operate, transfer. Let the government do it, and we'll always be there to provide whatever little help we can give.
And what about the mechanism, if there is any effectiveness, like how do you prove the effectiveness of the entire ecosystem and training system which is happening?
Yeah, so as I mentioned to you, there are over 57 publications from India, and various aspects have been studied. whether the knowledge improvement takes place or not, whether the healthcare worker, what is his isolation goes down, he feels more confident. All those effective strategies are there. And they are published in reputed journals. So we try and give them, and we try and give an overview that there's now reasonable proof in last 10 years that this model works.
Great. So, do we have any other questions on the floor? Anyone? Otherwise, we will wrap up the session quickly. And so I think with this note, I would like to thank Dr. Kumud Rai, Dr. Colonel Kumud Rai, for this wonderful session. And I would like to thank all the medical associations for joining in, and also thank you for the support for the tragedy which happened. So with this note, we would like to end the session, and everyone see you again next week. Thank you. Thank you, Dr. Kumud.